All righty. Thank you, Madam Chair. I appreciate you holding this hearing. Dr. Evans, this question's for you. I'd like to ask you about crisis care funding. Last session of Congress, I introduced a bill called the Crisis Improvement and Suicide Prevention Act. It's legislation that directs 5% of the $750 million in the mental health block grant to be used for crisis care services. I know you know this, crisis funding helps mental health providers all over the country. Specifically in my district, we have Rosecrance and Rockford, the Robert Young Center for Community Mental Health in the Quad Cities where I live, and Unity Place in Peoria, Illinois. And it funds crisis call centers and mobile units to travel to patients who are in crisis. I want to thank you for endorsing the legislation that we wrote out of our office. And I also want to thank Chairwoman DeLauro for passing this set aside into law in last year's funding bill. My question is this: how important is crisis care funding during and after? Because I think we can start looking a little bit ahead, cross our fingers, but during and after the COVID-19 pandemic. And then how much funding do you think we should provide the crisis care set aside as we move forward?
Yeah. So, yeah, first of all, thank you for your support for these services, which are really essential in the community. I recently had a personal situation where I was helping a family friend access services. And what happens for mental health conditions, unfortunately, is that mental health systems are different in every community. And so it's very hard to figure out where you go for help, how do you get access to help. And I think what this funding does is it provides really a floor for mental health systems to make sure that they have the minimum kind of services in place so that when people are in crisis, they can reach out, they know how to reach out, and they can get help. So I think it's very essential. I also think that it's important to think about what comes before and what comes after crisis services. And to me, as someone who's run mental health systems who ran mental health systems for many years, that is as critical as the crisis services themselves. Often there are not enough alternatives to crisis. Many of the people who end up in crisis services are there because there simply is no other alternative. I know people, for example, who will go to an emergency department and say that they are suicidal just to get help for their substance use issue or for their mental health issue. And then on the back end of crisis services, we want to make sure that people have um, available services, because what happens is if people go into a crisis service, they get admitted to a psychiatric facility, and there's no aftercare immediately when that person discharges, it significantly increases the likelihood that that person is going to recidivate. And so crisis services are essential. We need to have a basic way that everyone can access those services when they need them, but we also need to make sure that we have alternatives, and we also need to make sure that we have continuity of care so that people don't have to get into that cycle.
All right, Dr. Evans, follow-up question for you. The National Institute of Mental Health says that more than 60% of rural Americans live in mental health and professional shortage areas. Uh, Rural America is my district. It is mostly rural geographically. And so, just as an example, we have 14 counties in the congressional district I serve. 9 of the 14 are considered mental health shortage areas. Stevenson County, Joe Davis, Carroll, Whiteside, Henry, Henderson, Warren, Knox, and Fulton are all rural, and there's a shortage there. That's why in the December funding bill, I was lucky enough to be able to include language that encouraged Health and Human Services to increase the behavioral health workforce education training program presence in rural areas. And I also introduced something called the Rural America Health Corps Act that supports 5 years of loan forgiveness through the National Health Service Corps for providers who commit to serve in rural areas. So, how else do you think we ought to be working with Health and Human Services to combat mental health provider shortages in rural areas besides what I just mentioned to you?
Great. I'm so glad you asked this question. This is a high priority for the American Psychological Association. We've been working with organizations like Farm Aid and other organizations to look at ways that we can help get more providers in those areas. The loan forgiveness is very important, but it's also important to fund and make sure that we have Medicaid expansion. And the reason is, and particularly in rural communities, and you would know this, is that hospitals often are strained by the number of people who have or who are uninsured, the uncompensated care. When those hospitals go away, often there is no behavioral health care provider in those communities. So we have to look at making sure that the individual is also covered and that their services are going to be covered in the providers that are in those communities. And we also need to make sure that we train providers to work in rural communities because there are unique issues. Farmers, for example, have a suicide rate that is significantly higher than the rest of the population. They have unique issues, and generic mental health services often aren't responsive to the unique strategies or the unique issues that those individuals are facing. And so we need to have a range of strategies to make sure that we shore up those services and that those services are appropriate for the people in those communities.
Dr. Evans, thank you very much, especially for your grasp of these issues that are so important. Madam Chair, I yield back.